Good afternoon to all of our OC3PR listeners. I trust all are well as we continue to be challenged by the ongoing COVID pandemic. I'm sure we all recognize the incredible emotional and psychological burden this is placing on our colleagues and staff. Unfortunately, the challenges will likely continue into the fall and winter, so it's important that we continue to work together, share the load, and be prepared. It is with that premise that today's webinar is certainly timely, as it aims to discuss the preparation and strategies that are in place to ensure we have contingency plans to care for all children, our kids, should COVID begin to further impact our healthcare system and challenge its ability to care for the sickest children amongst us. The Ontario Critical Care Clinical Practice Rounds is the ongoing webinar series from Critical Care Services Ontario to help prepare healthcare professionals in their ability to address concerns like pediatric critical care surge, but many other challenges that impact critical care teams as they care for critically ill patients. Our speakers today will be again taking questions, which we ask you to submit to one of the Q&A that you can find in the chat. Today's questions are fielded by Dr. Josée Thériault and Neill Adhikari. This webinar, along with previous, are available at CCSO website and their YouTube channel. Everyone's been doing a great job at keeping yourself muted, and we ask you to do so again today for the sake of others. Consider following CCSO on Twitter and check out their website for ongoing updates and other valuable resources. When concerns surrounding COVID began to increase in earnest in early 2020, I think all of us were reassured to see that COVID seemed to be sparing children. The impact was certainly borne by our elderly, and the number of affected patients seemed to decrease by their ages. Our pediatric colleagues were not seeing COVID in kids and were able to help us care for adults suffering from COVID by taking adults into their pediatric intensive care units. It was therefore alarming for all of us when we began hearing reports, especially from the American southern states, of an increased number of children suffering from COVID, including some deaths. Clearly, whether you're a parent or not, I'm sure you share my sentiment that we must ensure that our system is able to care for all pediatric patients, no matter the means or the cost. We therefore are delighted to have with us today Dr. Elaine Gilfoyle and Dr. Sonny Dhanani to bring us an up-to-date review of what the impact COVID is having on pediatric patients and how our system has made contingency plans to greatly increase its ability to provide care for all children should the unthinkable begin to happen. Dr. Elaine Gilfoyle is the division head and medical director of the PICU at the Hospital for Sick Children in Toronto. Prior to this, she was a pediatric intensivist in Calgary, where she was also the director of research there. She completed her medical degree and residency in pediatrics at the University of Western Ontario before completing her pediatric critical care fellowship at McGill University. She has a master's of medical education with a research focus now on pediatric resuscitation with an emphasis on human factors and the use of simulation. Elaine is the current chair of the Critical Care Medicine Exam Board at the Royal College, for which she is the first pediatric intensivist to hold that position. Dr. Sonny Dhanani graduated medicine from the University of British Columbia prior to completing his pediatric and pediatric critical care fellowship at the Hospital for Sick Children in Toronto. He's also had additional training at the Great Ormond Street Children's Hospital in London, England. He's the current chief of the Paediatric ICU at the Children's Hospital of Eastern Ontario, a place our region affectionately calls CHEO. He is an associate professor at the University of Ottawa and has been recognized throughout the world for his research and many achievements, particularly in the area of organ donation. Sonny was once the chief medical officer and medical lead for Trillium Gift of Life, which is Ontario's organ procurement program. Currently, he co-chairs the Provincial Pediatric Critical Care Advisory Committee and is the chair of the Canadian Donation Physician Network, and the chair of the Canadian Blood Services National Deceased Donation Advisory Committee. And I thought OC3PR was hard to say. Geez, Sonny. Our objectives today for today's webinar is to review current pediatric critical care capacity along with surge response. They will review the impact that COVID could have on pediatric critical care capacity, including processes to mitigate such increased demand. They will identify specific issues that might impact pediatric critical care surge. That said, I think if there's an underlying theme or tone for today's talk, is that of reassurance that there are plans and strategies in place to ensure care for our children will be there should the need arise, but that this response may require help from all of us. Elaine, Sonny, thank you both for taking the time to come present to us today, and I look forward to your presentation. And Sonny, I believe you're going to start us off. Thank you both.
Thanks, Dave, and the rest of the organizers. On behalf of Elaine and myself, I think a really fantastic opportunity to share and have a discussion and important topics to us. So thank you for the time and for all of you joining us today. What I'd like to start is, I think Dave gave a nice preamble about what we'd like to talk about today. And really, I want to spend a few minutes to start talking about some situational awareness. I assume that pediatrics and pediatric critical care for most of you may be a bit of a black box. I'd like to open that box just a bit to talk about the stressors that we have in place right now, and then to discuss opportunities where we may ask for support if we need. So really, we're going to talk about why we're having this conversation a little bit, how we've got to this point, and the resources we're using to build a plan, as Dave said, to create some reassurance and a system in place. And Elaine will go through some of the details of what we're proposing together and how we might do that. When we talk about pediatrics in the province, there are 5 tertiary care centers: London, McMaster, Sick Kids itself, Kingston, and CHEO here in London. I'll give a shout out. Sick Kids was just voted in Newsweek magazine the top children's hospital in the world. And that's an amazing feat for them. So we're very proud to have them as part of our fold. But I think what's most impressive, though they're by far the biggest center, we have an amazing collaboration between all 5 centers. 4 level 3 centers that take ventilated patients of all types, trauma, neurosurgery, and all subspecialties, chronic ventilation patients. 2 of the centers, CHEO and Sick Kids, have cardiac ICU patients as well. Kingston is designated a level 2 patients where they can take ventilation, but only for short periods of time. All centers do non-invasive ventilation as well. 2 of the centers are freestanding, that's CHEO and Sick Kids. And the other 3 centers are associated with their adult hospitals, and I'm sure the collaborations are great there. We're not going to talk about neonatal ICUs. There are many neonatals, level 2 and level 3 centers. Those are for premature babies and infants that are perinatal. For PICU, we take 0 to 18 years old at all these centers. And sometimes we do take premature infants or early gestation infants, but those are usually related to cardiac surgery. There is one more long-term ventilation center called Holland Bloorview, but that does not handle acute capacity and basically supports the GTA area. So that's kind of where we are as a province. And we've been working really well together to manage our normal stresses. And usually we see our mini pandemic every year. We have our recurrent virus, RSV, among others, influenza, the regular coronavirus that creates a seasonal surge every fall, about November and December, and then another surge in February and March. And we tend to create strategies to manage these patients on our wards, in our emergency rooms, and particularly in our PICUs. From there, we've recognized that there might be some changes this year. This is some data from Australia, and you can see the green bar that shows the regular surges that come up. They're backwards because their winters are in the summer, but you can see this normal 2-phase spike. But what they saw after COVID was this huge lift in admissions related to RSV. They're accounting this to something called the immunity debt. For 2 years, we've kept children inside without going to school, without access to the regular flora that we get from snotty noses. All of a sudden, everyone's back at school, they're back at the park, and RSV hit them hard. We're worried about this. We've already seen a surge in RSV in our hospitals. It's starting to trickle into our ICUs. And this is almost a month ahead of time. And we're almost seeing double the amount of activity already. And so we're worried that we're going to see a huge surge like that occurred similar to the Australians. We barely make capacity in routine years, and we're worried that this year may be an extreme situation. On top of that, the topic at hand is COVID. And in August, we saw what was happening in Texas. Catastrophic numbers of admissions, high rates of mortality. I'd say our PICU mortality is only about 2 to 3% in given years, and their mortality soared, especially with COVID. To be honest, we panicked. We were worried that this was going to spread across North America. We were reassured. In other areas that were highly vaccinated, like the UK, we saw a rise in the COVID cases amongst children, but we didn't see the correlation with ICU admissions, and especially we didn't see mortality. Locally, we took those two models, and the science table here looked at some modeling based on some local numbers extrapolated to the province, looking at pre-existing levels of how we were mitigating contacts and vaccinations. And to just point out, looking at the under 20 group, which is the red, orange, and yellow, you could see that they estimated for certain ICUs a fairly modest increase in the number of ICU patients, 8 to 10. And if you looked at a peak CRCI, maybe come November, December, they said potentially you might see 87 COVID-related patients. Now, for many of you who work in adult sites and what we've been dealing with, especially in wave 3, that may not sound catastrophic. But let me show you a little bit of why we're worried about those sort of numbers that may not seem so worrisome at first value. We've already seen the surge in number of COVID cases under 17 in public health numbers. They are increasing. So our worry is with RSV peaking and with a peak in COVID, our system may be stressed. Already right now in September, our emergency rooms are absolutely filled. Our wards are displacing patients, and our PICU surges capacity is full. It's full already. Here's some numbers that may help explain the gravity of our situation. Our baseline numbers might be surprising to you. If we look at what we have for pediatric ICU for the entire province, we estimate about 73, 74 level 3 staffed beds. Most of them are at sick kids, and then each of the ICUs have 4 to 12 level 3 ICU beds. There are a number of level 2 beds as well that are short-term, possibly chronic ventilation, that don't have capacity to manage acute, say, COVID or RSV. We looked at what sort of capacity we would have to increase the number of beds, and this was actually an exercise done for the adult surge in wave 3. These would not be sustainable beds, but with shutting down operating rooms, opening up spaces like PICUs, using existing ventilators, how many extra beds could we get? maybe we estimate to a max of about 37. So we're looking at about 100 beds total. And if we're already filling 75 of them now, which is basically where our census is now, looking at 80 more COVID patients in the middle of December obviously is really challenging. Right now, we're trying to create capacity in non-critical care areas because it's not just about admissions to the ICU. I think we've all recognized it's about flow through to the hospital, working with our community partners. What's different in the pediatric situation is that there are only 5 tertiary care pediatric centers that can admit these highly intensive acute care patients. We don't have the community-based model to be able to decant some of these patients to those areas. So this is it. This is it. This slide is it. Where are we now? In fact, this is a couple of days old, but our bed occupancy in the pediatric ICUs are high. You can see sick kids on this slide is a little bit lower, but I think for the most part, including today, they're back to 100%. So we're stretched, and we're stretched now, even before the push of RSV that we're expecting and the possibility of COVID that might come. I think we're reassured that we're not going to be Texas and that we may follow, at least with the COVID scenario, a more UK-based model. And our current modeling is being adjusted to fit that model. So with that situation, and those stressors, I think what we've been doing is working with the CCSO, and we've got the Pediatric Critical Care Advisory Committee that has all the medical and administrative leads from the 5 tertiary care centers involving Critical, Orange, other transport mechanisms through PCMCH, Ontario Health, and then the Ontario Critical Care COVID Command Center that I think was instrumental in managing wave 3 for adults. That group has absolutely helped us build and base a strategy for support for pediatric ICU if and when we need that. What I'm going to do is ask Elaine to walk us through a potential model of support that would involve adult ICUs. And we'll have more questions at the end. Elaine, I'll pass it to you.
Thanks, Sonny. So we don't really know what the next few months are going to bring. Sonny outlined very clearly how we could be really stretched beyond our usual winter surge. But we thought we'd be proactive and develop a sort of phased in approach to how bad it could be at different stages. So we're going to present those high level points to you now, and we very much value your feedback through the Q&A section or through your regional reps through the various command tables. So we would like to hear back from you what you think about this, but this is what we've put together for now. So we all learned a lot from wave 3. We, as you know, we helped out as much as we could in caring for adults in April and May and June. What we all learned, and we spoke at various different tables, and I heard this over and over again, is we've all learned that we really need to treat critical care capacity as a single system resource across the province. And we were really grateful to be able to help out the system that was challenged on the adult side up until now, and are wondering how you guys could potentially help us should we get overstretched. And we also have the added need to always remember that we have obviously tertiary and quaternary services at our various sites that are, there's, for example, some of the services at Sick Kids there's really the only site in the province. And so we have to be able to maintain those while trying to care for any seasonal patients who come in. Next, Sonny. So we've already begun discussions, as I mentioned, this is one step, putting a plan together about how we could all help each other. And I will note that although we're not talking about NICU today, as Sonny mentioned, we've always worked closely with our NICU colleagues because we do overlap in certain patient populations, whether it's neonatal surgical patients or older infants who require chronic ventilation. And so we've already had those discussions locally with them about how they can help out too. Not with COVID adolescents. I don't think they're going to be too happy with that, but there's certainly other patients who we take care of that they can help. So we, as well as you guys, put together staffing plans for how we would take care for patients in our surge beds. including putting together team-based models, et cetera. So we have all those ready to go. We have not had to implement them yet, but are planning to do so should we need. Next, Sonny. And of course, if we need to, we've got our existing regional IMS structures that work so well during particularly wave 3 to maximize capacity across the province, and we're prepared if needed to use those for pediatric patients as well. And although this is very short term, I don't know what short means, but short term for this pandemic. But really, this could take a new lens approach to the province in terms of surge capacity for the future. So that's something we can talk about after the fact. We've divided our proposal into 3 phases, with the second phase being divided based on whether each individual community hospital has a pediatrician's availability and pediatric inpatient service. So I'll go through each of those phases in a bit more detail. So this is where we're at now. So as Sonny mentioned, we're already full. We've already been deferring patients to each other's centers as beds come up. We've already been canceling ORs. So this is before we really see any COVID in our units, as well as really any RSV at this point. As throughout the province, nursing shortages are also affecting our hospitals. And so we're challenged by our lack of ability to expand up our beds as we usually do each winter. And of course, we have internal needs to transfer patients back and forth as well, and that won't stop. So we have to make sure we can figure out how to prioritize them. And what we're really pleased about now is that our inpatient general pediatric colleagues are now not being as overloaded with ward type patients as they were during wave 3, because the pediatric inpatient ward beds have been opened up again. And so children are staying locally on the pediatric inpatient wards, whereas before those were being seconded for internal medicine. So they've opened up again. Next, Sonny. So phase 2, which we'll go through the next couple of slides in terms of detail, that's what next phase would look like when we start to see some COVID numbers or other numbers go up beyond where we're at now. And that's really where we decided that based on our ability to activate some of our HHR plans, that we would consider ourselves overwhelmed. And so we would continue to have conversations on how we would implement these phases through our regional command tables before we would formally implement them and make sure that all the plans are in place and finalized. Next. So we're dividing it up into two possible options here in phase 2. One is that critically ill children show up in a community hospital and they stay there based on the appropriateness, which I'll go through in a minute. Or patients show up to our site and we need to transfer them out to appropriate community ICU. So Sonny and I thought what we would do is start with what we're not going to ask you to do, because there's probably a lot of anxiety about that you may never have seen in your career, and you're wondering what the heck would be potentially asked to help out with. So we are not going to be asking you to treat small children with congenital heart disease. We are not going to be asking you to retrain and become a pediatric intensivist or nurse or RT or pharmacist or social worker. And most importantly, we're really not asking you to manage patients that you haven't before. And I'll go through the details of that in a second. This is hopefully very, very short term, if at all. And you will not be alone. So Sonny and I and our colleagues at our various centers would be there with you over the phone, et cetera. And I'll go through that in a minute on how we could support you if you did keep a patient there, if you had questions. And we certainly capitalized on all of your expertise when we had adults. We were on the phone with lots of you multiple times a day. And so we would assume the same should you keep critically ill children. So we would obviously, getting before this phase, look at how many more surgeries we could cancel, just as a point of, and I don't know how this compares to the adult world, but for us, about half of our surgeries are emergent and half are elective. So it's only going to be so many children that we can actually cancel the surgeries for, and only so many hospital admissions that are considered elective. They're almost never. So that's going to be limited as well. And we would only want to transfer patients or keep patients in an adult ICU if pediatric subspecialty services, whether that's medical or surgical, are not required, because we appreciate you don't usually have those available to you locally. And so if a patient's already being followed by someone of a subspecialty service, then we would do our very best to prioritize those patients coming to a tertiary care center, ideally the same center that they have been cared for to date. Because again, we realize you don't have the same subspecialist support that we do. So this is what we're proposing. We're proposing to consider limiting the patients who we would keep in an ICU, an adult ICU, to patients who are 15 years and older and who are 50 kilos and above. And the reason we've picked those numbers is because generally patients 15 years and older are post-pubertal and their physiology is the same as an adult. And 50 kilos is generally our cutoff for when we start using adult doses of medications and adult sizes of tubes and lines. And so we realize that calculating medications per kilo is not something you guys do a lot, and it creates some anxiety, and wonder about the physiology of certain patients being different if they're prepubertal. So we've proposed these limits to try to reassure you that any patient we would consider you helping us with would really be a very similar patient population to who you already care for in terms of size and age. And then diagnosis, Sonny, if you can just show the next bit. So you'll see more than just COVID listed here. And I appreciate that through the IMS structure that we had before, we only took COVID adults. We didn't take non-COVID adults, although we did talk about that. But we decided to brainstorm, be a little bit more broad when we were thinking of the types of patients who we actually, frankly, overlap with you guys on. And older adolescents could be cared for the same way in an adult ICU and a pediatric ICU with these diagnoses. Recognizing that COVID would probably be the preferable diagnosis if you had a COVID adolescent. But I looked at for just as a point of interest, I looked at our local data of 15 and above and the diagnoses that they had. And another patient population we get a lot of are patients who have overdoses. So that would be potentially a patient population who may show up and we may not have room for and feel confident that you guys could keep because they would be managed the same if they were 18. Next, Sonny. Of course, support is extremely important, and we envision that how this would happen is that through the normal route. So if a patient shows up in the emergency department in a community hospital, then generally be the pediatrician who gets called to support the patient, whether they're not critically ill or critically ill. And if the pediatrician felt that the patient required transfer to a tertiary care center, they call us through Criticall. Sometimes the emergency doctors call us directly, but often it is through the pediatrician. And then we make a decision on whether to transfer and whether to transfer to ICU or to the ward. And we're, of course, available through Criticall 24/7. So we envision that if an appropriate adolescent were to show up in a community hospital, the pediatrician assesses, then we would have a collaborative discussion with both us, the pediatrician, and the adult intensivist at that hospital about the appropriateness of that patient staying there locally or coming to a tertiary care center. So it would be a joint decision. There are some centers that we are expanding, every day, which centers have the option of virtual critical care through the OTN platform we're using called Trauma Tenant. And so then some of those centers, we may be actually able to do a video conference if that may be felt to be useful in terms of making decisions around disposition. And of course, through the bridge calls, the Criticall, we can actually bring in other of our interprofessional colleagues to give more advice, whether it's ventilation or medication administration for nursing or pharmacy. We can bring up those people as we need to. And if there ever was a need to ask a subspecialist a question, we can bring them onto the line as well. And I mentioned the role of the pediatrician. They would stay involved and hopefully keep the patient after they're ready to be discharged from the ICU, but again, that could be a collaborative decision at the time. We envision that the majority of these patients moving back and forth would be through Orange, but most of our centers either have or are planning to have in the short term a critical care transport service for children. And so those resources are also available to move patients around as we need. So we're all locally having discussions, not just with our ICU colleagues like today and through our regional command table meetings, but with our pediatrician leads, because of course they have to be partners with us in these decisions and the planning for this. And they're quite keen on helping as much as they can. And they actually missed caring for inpatients throughout wave 3 and are now doing it and looking forward to continuing to help out the system and use their expertise in caring for children who are needing to be hospitalized. But of course, they need to be part of the decision around transfer if the patient were to get worse. Again, we talked about prioritizing patients who need more tertiary level centers or repatriating patients back and forth. Those are decisions we could make as a one-off, recognizing the individual factors of the patient and the surge capacity at the time. And of course, if needed to be repatriated, we would repatriate ideally to their local center. And if follow-up is required, then we would help to make sure that that is true. So for example, if a patient with an overdose did stay in a community ICU, then we could help to make sure that mental health resources are available for when that patient recovers. And phase 3 is one we're hoping never to get to. And this would be whether we consider out of province transfers or setting up a satellite PICU somewhere. And those would be very individual discussions within the regions and all through the province-wide command center structure that we still have and used very actively during the previous waves. These are the leads, the medical and administrative leadership leads at the 5 centers that Sonny mentioned. And we can get everybody in contact as required. I think that's it. So Sonny and I want to thank you for taking the time to hear our proposal and our thoughts on how you could be helpful. We're hoping that this isn't needed too much, but we really just didn't know. We wanted to be proactive given what we were seeing with our colleagues down in the US, that we didn't want to have to scramble if that was happening all of a sudden up here. So thanks for your time. We look forward to your questions and comments.
That's great. Thank you both. I mean, everyone hates a vacuum, so reassuring that there are plans in place, I think that's probably the most important thing to get out there with it. I guess I'll start off with some questions before going to Josée for the next. For me, the majority of patients with RSV, now it's been a little while since I did pediatrics, are infants and under 3. So I don't think you want me personally caring for those patients. I won't take offense, don't worry. I'm sure Sonny would let me care for his mom, so that's more important. But what is your proportion of patients in the PICU that, let's say, are above 15, ages 10 to 15 and below? Because I think what we're focusing on is what are we going to be as adult intensivists and adult ICUs? What we're most comfortable is what looks like our usual patients.
Yeah.
So any idea on proportions that we could think?
So I don't, and Sonny may, but I don't have the numbers off the top of my head, but definitely the majority of our patients are toddlers, infants and toddlers. And so that's why we expanded the potential list of diagnoses beyond COVID. We appreciated that when we helped you guys in wave 3, we kept it to COVID patients. But really, when we looked at the numbers, we weren't sure. It depends on how COVID affects our adolescents, but now that they're mostly vaccinated, who knows? But we didn't know how much of a burden that would be on us. And we wouldn't expect you guys to take the toddlers and infants with RSV and other conditions. So we created that list, like trauma, burns, overdoses, that those aren't COVID patients, but those are patients that you do care for now because essentially they are the same as an adult. And that we may ask you to keep, so that we could keep room, little room we have, keep room for the infants and toddlers who we absolutely wouldn't expect you to be comfortable caring for.
That's great. Maybe I'll add to that too. I think the worry that I've heard on the command center is, that the adult ICUs have HHR problems now, that everyone's, pretty tired, and to create an extra burden now after dealing with COVID for many, many months. How are we going to manage this? We'd like to help, but how are we going to manage? What I think we'd like to reassure is that the burden, the numbers are probably not as high as you think they are. We did a quick screen of the last 3 months of the provincial admissions to PICU over 15 years old. It was about 40 a month, 50 a month through all the ICUs. And in fact, so if we take a say half of them that might need to be admitted across our adult ICUs for particular acute illnesses like overdoses. You know, I think it feels much more manageable to be able to distribute a dozen or so, or maybe 2 dozen, which may not seem like a ton for the adult critical care capacity, but for us, it would be a huge percentage of open door for the RSV under 5 that wouldn't be able to be treated anywhere else, or those cardiac surgical emergent cases.
That's great. And I can't speak for every intensivist, but I'd actually go so far to say I'd rather treat the non-COVID, non-ARDS adolescents as opposed to, you know, the atypical child that's or young adult or whatever is the correct term. So I think your choice to include the others is actually preferred. Josée, I'll go to you, and then I'll flip over to Neill.
Dave, thank you, Sonny and Elaine, for this presentation and opening our eyes and letting us peek into the pediatric world. Coming again from the north, where we don't necessarily have PICUs, this is really, as Dave mentioned, a bit of a void for us. So I think this was super important. So thank you again. I would like to start with just a comparison. I know what we've done in the adult ICUs, but I know you guys cared for adult patients, and I'd be interested to see and to hear what your nursing model was for those adults that came into your units. Because just looking, even if we do get a surge and we end up having adolescents on adult ward, or even younger patients, what would that represent? So it would be nice to hear how you established your staffing models for the adults you had in your hospitals.
I'll ask Elaine to start because they took far more patients than we did.
So we ended up caring for 44 adults during wave 3 at SickKids, and some of them were for many weeks, including I think 6 on ECMO. We kept our typical nursing ratios as we should have been a child. So it's 1-to-1 for patients who are intubated. And if we have a patient on ECMO, we have an ECMO specialist as well. But it was the same as we would do during normal too. But we developed it, we tested it out, we're ready to go and adopt that model if we get to that point, but we didn't need to. So our typical nursing ratio is 1-to-1.
Yeah, and what I'll add to that is I think during the time that we were taking adult ICU patients, our pediatric census was unusually low. Kids weren't going to school, they'd been shut down here in Ontario. They weren't going to the parks. Immunizations had just started, but you know, I think we were not seeing the burden. And so we had the ability to stretch and do 1-to-1 nursing. That's different now. And so that's part of our concern now is how do we create models that are sustainable? And I think we learned a lot from what adult centers do as far as the team-based modeling, and especially with the hiring of many junior nurses to try to, regionally increase our capacity to admit and be sustainable, that the team-based model is the way we'll have to go.
Thank you. I was wondering, did you integrate adult nurses as well to help, or you just relied on your pediatric nurses?
Our adult nurses were very busy. So we didn't feel we could ask them to come and work extra shifts with us or whatever. But what we did do is send some of our nurses, for me, it was just across the street to Mount Sinai and Toronto General. They went and walked around and spoke with the bedside nurses, the nurse leadership, and we developed some of our plans and practices around mobilization and proning and all those things based on what they had learned from the adult ICU nurses.
Yeah, we did the same. We did the same, and I think to add to that, the CCRT model, with an RT, an RN, and a physician, And that constant communication between the two teams was a huge win and very supportive. And I think that it added to the value of the care.
Okay. So you would see the value of either sending some adult nurses to the pediatric wards and have an idea of maybe for those older kids, if there are differences and things like that, would be welcome.
Yeah. Oh, they would be absolutely welcome. Yeah, absolutely welcome. And I think, again, it's about communication and collaboration. And I think our team quickly felt comfortable with the patient population, despite on paper looking so different, that once they were in the ICU care actually was very, very similar, very, very similar. And I don't know if the word surprised, but we were comforted by that, after the first one or two patients came.
Thank you. I think that's a very important comments, is that that unknown and uncertainty, and to have had that experience. So thank you for sharing that. That's very good. Dave, I would have another question if I may. Okay. So there was a question about in phase 2, when you describe or mention your system is overwhelmed, we're wondering if you could elaborate for you what overwhelm would mean, or if you could clarify some of those markers.
I'll start. I think we currently often feel quote unquote overwhelmed on any given night when we have a patient that might be, for me, Queensway, which is 15 minutes away, and we have no nursing or physical capacity, whichever it is, to admit that patient, and we have to organize a transfer to SickKids from the Queensway, which is 1 or 2 hours away. That feels overwhelming, but that for us is something that we've managed and we encounter on a yearly basis, to have that flexibility in the system, to share amongst the 5 units, to try to keep patients in their region, but if not, to work within Ontario and make sure they get quality care. I think we're going to feel overwhelmed when the Ontario system can't manage that, when we don't have capacity within our 5 hospitals to accept patients that need pediatric intensive care, especially the younger patients. I think we're not there yet, and that's a evolving state, but that's where we're going to feel, and we've got census numbers, and if we're creeping over our census, we're already near 100%. And the idea on a given night that we may have to send patients outside the province or put them in unsafe areas within our hospitals, that's when we're going to feel overwhelmed. Elaine, if you have any thoughts on that.
Yeah, I'll just add, just concretely for me, on a given night, if for my next admission, I'm pulling my charge nurse. I've already got some of the emergent OR patients recovering in PICU, and I'm not actually sure how I'm going to manage the next patient who comes, because a lot of our patients come from internally, like, a bone marrow transplant patient who goes septic, and it's not like I can transfer them somewhere else. So I worry that's what keeps me up, is the what if, or if so that's why, we tried to expand the list. So if I already know I'm at that stage and I get a call from our community pediatrician who's got a 17-year-old who's taken an overdose of an SSRI, I am 100% comfortable that the adult intensivists at that hospital would do equally as an effective job and a very skilled job of managing that patient. And I worry about taking my bed that doesn't exist, but squeeze them in somehow, when the next call could be a 2-year-old who can't go anywhere else, or that BMT patient who can't go anywhere else. That's what I call overstretched.
Yeah, great example.
Thank you. I think it makes the way you describe the type of patients where the prioritization between those older teenagers versus accepting a smaller child, I think totally makes sense. So thank you. Back to you, Dave. I don't know if you have any other.
Yeah, no, before we go to Neill, I'm just going to put it to Sonny and Elaine is how do we, what is the surveillance that is going on? How, how the province has the different color coded system for activity. Is there a way or plans on how we're going to let all of our partners know throughout the province, where are we at? When do we need to step up and do a little bit more? What's the ongoing system? I know the daily reports we get about COVID, I'm not sure it's as suited in terms of the pediatric. Is there an idea of what we can share with the different leads and administrators across Ontario of how are we going to follow this so we know what state you're in?
Yeah, I think the Pediatric Critical Care Advisory Committee is following those numbers and those admissions. But I think what I'm hearing is, something a little bit more concrete would be helpful. And you're right, color coding would be helpful. We have smaller numbers, so the difference between red and yellow and green may be smaller and flip very quickly. But to have some criteria that'll help us communicate with the community, on a call like this is going to be really helpful. I think that's really great. And what I'd add to that, we're so interdependent on our wards and emergency rooms, again, because there are fewer of them in the province, that, a dashboard like that with all those factors and partners is probably what we're going to need. That it's not going to be just the PICU, it's going to be all those environments that are going to change from yellow to red. Elaine, any thoughts?
No, it's a great suggestion that we could take back. We're now meeting every week as PICU leads, as Sonny mentioned before, which we weren't doing before, and we can scale that up to as often as we need to. And then we can continue to liaise through our regional ICU leads, as we did during wave 3, to be more specific about our local collaborators, but having a system that's a bit more transparent about how close we are to various levels of capacity is a really good idea.
No, that's great. We'll go to Neill next. I just remind everyone that please fill out the survey at the end. It does help us make the talks better and more directive. So please, again, take the time to do the survey. Neill, I'm going to pass it over to you.
Thanks very much for the presentations, and anyone in the audience, feel free to send your questions to Q&A too if you just thought of questions that you'd like to be answered. Maybe a couple observations and some questions. The first observation is that the decision on the thresholds of 15-year-olds and 50 kilograms to me makes a ton of sense, especially because working in a trauma center, we routinely keep patients age 16 and above, and possibly even 15. I just can't really remember. And for that type of patient, most of the surgical services seem reasonably comfortable with that, in my experience. So I don't think that would be much of a departure from usual usual practice. I was wondering if you had to go any lower than that, like to the 10-year-olds, to the 10 to 15 range, what the implications would be, not just for the health human resource expertise, but also for equipment and material and disposables and stuff, and whether that's sort of entered your thinking.
We're definitely thinking about that scenario and the potential creep into stretching our boundaries a little bit. I think we want to stay with our principles to make sure any patient that would be treated outside of a PICU, would have a disease process that the adult intensive care team would feel comfortable with, that they would have the ability to manage those problems. And, you know, I think if it got to the point where size was an issue, then we will have to, which we've already started working with the teams like pharmacy and nursing and RT to make sure that equipment and drug dosing would be managed well. And of course, the continued support with, you know, the PICU MDs and the CCRT teams would have to support that sort of thing. I will say that we're thinking that won't be the scenario, that especially with the way the COVID numbers and the surge has not panned out so far, that we think that won't be the case. But I think you're right, Neil, we should plan for it. I will reflect that when we started accepting adult patients, we had some pretty strict criteria, David will remember, of, you know, under 30, and then it went to under 40 years old, and we had much older patients come, and we managed with the support of the team. And I'd hope that if we got into that scenario in reverse, that we would be able to, we would absolutely be able to manage together.
The only thing I'll add is it's a great question. Generally, this elementary school age children are a healthy bunch. And so we have to look at our local data, but I imagine that the types of patients who we get in that age range are actually quite subspecialized, you know, surgical or complex medical oncology, things like that, who wouldn't really be suitable, whether it's their age or their diagnosis. Have to look at that. But that age range is actually, they're generally pretty healthy. So I, off the top of my head, can't imagine that there's a decent size or number of patients in that group that would be suitable, but it's something we could definitely look at if we needed to get there.
Thank you. One question from the audience around the criteria is currently stated. Do they have to meet both the age and the weight criteria, or is it sort of either one? Like,
well, we're trying not to be too rigid about it, because as Sonny just said, when we helped out with in wave 3, those criteria that, like I had said, under 40 and under 100, what did I say? 100 kilos or something, because we didn't have the proper lifts or whatever initially. And then we had patients in their 50s and 130 kilos, whatever. So we're trying not to be super rigid about that. The point to me, the most important point is that they're post-pubertal and they're big enough. But if you had somebody who was post-pubertal but was 48 kilos, I'm not sure that makes a huge difference. But it would be, again, we envision the model being a collaborative decision around an individual patient based on their diagnosis and the surge capacity at each site and the comfort of all the clinicians involved, including PICU, general pediatrician, and the adult intensivist at the time.
I think it's a starting point is the way to look at it, and it's where the discussion is. And I know as we sometimes get younger, you know, suddenly we actually measure in hours of age, it seems. But I think the idea and the principles and that what are we comfortable, and more importantly, what is safe for the individual, that I think that's the big take home message. I take it from it. And, you know, we would still, you know, send Sonny, you know, if he had gotten sick, I think Gio would have taken him, even though he's well above a lot of the initial markers that we did. So I think if they'll take a Sonny, we'll take someone who may be a little bit more.
Oh, barely 30 years old and barely 50 kilos, barely.
I was teasing him. He can now shop at Shoppers, I believe, on is it Thursday that you get the deal, Sonny?
A little bit older, you're right. There
you go. Josée, I think you have one last question, and then we'll do some closing comments.
Thank you. I really like some of the comments that were made about having like a color-coded phase that would be like a real time. And I know compared to adult critical care patients in the peds are often not in the ICU as long. So it may vary quite a bit and go from green to red in 3 days, but it would certainly allow that transparency. So I really like those ideas. I actually had, a few more questions, but I know we're a little bit pressed for time. Two things related to support. I think some of these questions were coming through at different levels. is one, if your system really starts to be overwhelmed and stretched and over capacity, will we still see that support provided as centers will be asked to keep even more children? So that's the first part of that question. And the second part, do we know if there's appetite to pursue the expansion of virtual critical care for pediatrics across the other centers? So that would be my final two questions. Thank you.
Sure, I'll start with the first. Absolutely, that support will continue. I think we're pretty type A people, and we use Dave as an example all the time. If he's going to take care of a child or a teenager, I'm not going to let him do it alone. And so I think our whole team feels that way. I do trust Dave, but we're pretty protective. And so I don't think any center or group of team will feel alone. And we saw that from you guys as well. So, you know, we know even if we're busy, we'll find a way to make sure there's support. As far as VCC, I think that, you know, all the centers are looking into it. I think especially Sick Kids and CHEO have links with many of the centers, especially in the north. And I would not be able to answer whether we're going to, but I would say we should leverage this moment to try to expand VCC to more centers across the province as a sustainable strategy to manage how things work in Ontario.
As the #1 pediatric hospital in the world, this is the time to do this.
Elaine knows.
Congrats, guys. Congrats.
Thank you. I didn't know anything about that. I saw it in the news just like everybody else, so I have no idea what that's about. But yes, thank you. The only thing I'll just and it may help just to sum up how confident we are that this is okay, is that for my entire career in the last 20 years, I've always said that if a patient is admitted to the ICU and they bring a razor or they bring a bra, they really don't need to be there, because we treat these patients the exact same as your patients. And that was doubly emphasized to us when we actually cared for your patients. We realized there really was very little, very minor differences in the decisions we made about how we cared for these patients. It was really, it was confirmation to me of something I've been saying forever, that there really is no difference between a 17-year-old and a 19-year-old. And I know that you've been told otherwise your whole career about how special children are and how they should be cared for in these specialized centers, but that's actually not true for certain patients. So we thank you very much for at least listening to us and potentially being able to help us should we need it.
Excellent. Neill, I think you got one last question and then we'll sum up.
Sure, yeah. A couple questions are very related to, though, on the role of community hospitals in supporting this, and particularly on whether there's some potential planning for decanting ward patients to community hospitals in order to help out tertiary centers.
Elaine, you want to take that?
So can you repeat the question, Neil? I just want to make sure I understand exactly what you asked.
Taking patients that might be ready for discharge from a PICU to a ward, and rather than having them go to the ward at the pediatric hospital, go to a ward at a community hospital.
Oh yeah, we do that already all the time. We stopped doing it during the wave 3 when the pediatric wards were closed down and switched to internal medicine beds, but we do that all the time. Usually with specific diagnoses, for example, DKA, like diabetic patients who are cared for by their local pediatrician anyway, or patients with asthma who've recovered or whatever. But we do that all the time, and we'll continue to do that because we want to maximize the use of the inpatient pediatric beds in the community as well.
Right. I guess would that help you with some of the staffing challenges with if for example, ward nurses in the pediatric hospital were able to upskill to help in the ICU if they had fewer ward patients to look after, or if those patients were decanted?
Yeah, yes and no. So we're already pursuing that and flex training some ward nurses to be able to pitch in. But when we're busy in ICU, they're doubly busy on the ward with the same patients, like RSV patients, et cetera. So and when we look at more closely at the COVID data in the US, it's the wards that were stretched in more centers than the ICUs. So I'm not sure how much that's going to be possible, but I do take your point, and we're trying to flex train some of them just to help out if possible.
Thank you.
That's great. Well, I think time is our enemy, and I just want to thank again Sonny and Elaine for such a great presentation and a fruitful discussion. You know, I think if we learned one thing during COVID is how everyone has come together to help out other sites, and you certainly helped us with taking some adult patients. Sites have helped, you know, other regions share the burden, share the load. And I think they're, you know, not to speak for everyone, but I think the idea of helping out children, I don't think there could be a more noble cause. And so if we can certainly help out and ensure that the care is provided for all children, regardless of the location of the province, I think everyone's going to step up. I know you're going to be there to have our backs and make sure that we're doing it in a safe fashion. I think that's everyone's concerns, but I have full confidence. I know, you know, personally how CHEO has been involved. If we have a special case in our adult area, they come, they're available, and I can only imagine everyone would be the same across the province. So I think if we're all working together, we can get through this. And so thanks again, Sonny, Elaine, everyone, please take the time to do the survey. CCSO, thank you again for hosting this, and I wish everyone all the best. Take care.
Thanks very much.
Thank you so much, everyone.
Thank you.